Hi, this is Kyle. Welcome to my masterclass in Chapter 27, Part 2 on dementia. There's a lot of info, so let's go ahead and get started. One of the things they use to manage the progression of dementia are cholinesterase inhibitors. Their primary job is to prevent the cholinesterase enzyme from functioning in the synapse, breaking down acetylcholine, allowing acetylcholine to have a longer acting time. Again, it slows but doesn't stop the progression. It's most useful in early dementia, and its effectiveness varies depending on the patient. About one-third of patients have no benefit from them, another third have some benefit, and the last third have a very long-term benefit. Switching from one cholinesterase inhibitor to another is common, kind of a trial and error type thing. Cholinesterase inhibitors have side effects just like anything else: nausea, vomiting, weight loss, abdominal pain. Some specific drugs that were mentioned are donepezil, which is that top left one, and rivastigmine, the top bottom right one. Galantamine is another one. I can find a picture of that. They replace tacrine, which isn't prescribed at all anymore, not even from what I'm aware of. Memantine, which is an NMDA antagonist. I can go into that if you really want to, but I don't have the time. It's newer, and it's used in conjunction with the other cholinesterase inhibitors. I've seen it work wonders. Ergoloid mesylase, they used to be prescribed, but they actually were shown to not have any effectiveness. Some supplements that are prescribed are extract of ginkgo biloba, which seems to have some beneficial effects in early dementia, but the studies have been inconsistent. Vitamin E, because of its antioxidant properties, seems to help improve mental function. There's been a myriad of other supplements that have been studied, and they're not helpful. One way of managing the symptoms is by modifying the environment. For example, that I provide here, giving a patient a bath when they're viewing the world differently from before can make them combative. So just like what we do with patients on a table, we explain what we're doing before we go ahead and do it and start touching in places that normally would not be good places to touch. So just be forward with them, be upfront, and be honest. Learning how to respond to disruptive behavior is also very helpful because they view the world differently. They're going to be reacting differently. So the ultimate goal is to get the person calm and compliant. Drugs are not the best method, but they are used when other methods aren't working. Anticonvulsants, antipsychotics especially. Side effects of those are drowsiness, shakiness, and falls, but they can also worsen confusion, so there's pros and cons to that. Specific drugs that are used are olanzapine and quetiapine. They're newer, just as effective as the older ones, and have less side effects. Haloperidol and thyroidazine, those are still prescribed, but not nearly as often because of their side effects. Combination of these drugs is often used for behavior management. Trouble sleeping, just like with any other patient that we talk to, those who have trouble sleeping, we encourage to exercise if they're not already, bring their energy levels back down at night, have regular night routine, and avoid caffeinated foods and drinks late in the day. Some people say not past 4 o'clock. Drugs, again, are used when routine doesn't seem to help, but again, we're looking at possible increased confusion, impaired mental function, and risk of falling. Trazadone is a sedative that's much safer than benzodiazepines for this purpose. Benzodiazepines like temazepam can help, but there's a myriad of side effects involved with that when trazodone doesn't work. Treating unrelated disorders can be difficult because they don't necessarily are able to communicate everything that's going on with them. So it's our job to kind of see the untold symptoms of what they're going through. So one particular end-of-life issue you definitely want to take care of is make sure you appoint a healthcare proxy. You definitely want to know who is going to be making your medical decisions when you can't. With the advancement of dementia, you're looking at the shifting of types of treatments from prolonging life to just making yourself comfortable. So you're going to be using more aggressive treatments early on. They tend to be more uncomfortable, and less aggressive treatments later on, which is more geared towards comfort. So treatments can include controlling pain, skin care to prevent pressure sores, and attentive nursing care. Caring for them. Alzheimer's is the most common dementia in older people. It's rare under 60, affects 1 to 3% of 60 to 64-year-olds, 30% 85 plus. There's 4 million in the U.S. that's affected. Interestingly enough, they tend to be low on acetylcholine and have atherosclerosis. So it first occurs in the temporal lobe, that spreads all over the cortex, temporal lobe being the initial place for memory formation. General progression is they form neurofibrillary tangles within the cells, which ends up killing the cell, and then amyloid plaques bound to the cell, which, when formed large enough, will start spreading death along all the other areas of the cortex. The cause is not known. Seems to be a combination of genetics and environment, but genetics seems to be a more important factor. One protein that has been linked are apolipoprotein E. There are 3 primary types that we're concerned with. Type 2, some protection. Type 3 offers neutral protection, none. Type 4 offers actually negative effects and greater link to Alzheimer's development. Symptoms are things that we all think about or know about with Alzheimer's. There's memory loss, changes in personality, problems using language, disorientation, difficulty with daily activities, disruptive behavior. I didn't write it down, but anosmia and insomnia. Difficulty with abstract thinking, extreme and unpredictable changes in emotions and responses, and psychotic symptoms. The symptoms typically begin very subtly and progress over time. It's usually the patient that starts to think something is not right. The progression is unpredictable. From the beginning of the symptoms, you have about an 8 to 10 year lifespan on average. They eventually become very, very dependent on others, and after the ability to walk is lost, you're looking at probably 6 months of life left. And diagnosis is primarily based on physical exams and tests, such as mental status tests, blood and urine, CT and MRI. You see a picture there on the right. PET and CSF analysis has not been shown to be very useful, but true confirmation of Alzheimer's is done via after-death biopsy of the brain. Treatments are the same as any other dementia. Atherosclerosis is another factor that is corrected. Vascular dementia, aka multi-infarct dementia, is due to strokes, whether it be one or a few big ones or a lot of small ones. So neurological decline we're looking at occurring with each stroke, and the effects are dependent on where the stroke occurs. So things that they try to do to limit this is by limiting the stroke risk factors, i.e. high blood pressure, arrhythmias, diabetes, atherosclerosis, smokers. It often occurs in tandem with Alzheimer's. It's most common among men 70 plus years old. Symptoms, again, there's steps with each stroke and then a plateau of worsening symptoms. That includes memory loss, difficulty with daily activities, less severe judgment, personality changes, and they're prone to depression because they're more fully aware of what's happening versus Alzheimer's patients. Type of change is dependent on area of the brain affected, obviously. Death usually occurs 5 years after symptoms begin. Diagnosis is the type of dementia is investigated after dementia is even determined. What they look for is basically for stroke stuff. So think fast. Slurred speech, unilateral leg paralysis, difficulty walking, partial loss of sight. I know those aren't necessarily part of FAST, but those are signs of stroke. MR and CT are used, but not definitive considered. Treatment's the same for all the other dementias, with the addition of trying to limit those stroke factors. Lewy body dementia occurs due to unchecked deposits of Lewy body proteins in nerve cells. It's relatively common in 65-plus-year-old men, more so than women. The cause is unknown. The symptoms are similar to Alzheimer's, with the addition of Parkinson's symptoms. And in addition to those, you're looking at paranoia, delusion, and hallucinations. But the hallucinations can be pleasant. Lewy body dementia is diagnosed after dementia is determined again, so symptoms fluctuate from day to day. Visual hallucinations are possible and often accompany the same symptoms of Parkinson's. Treatment is the same as every other dementia.